Welcome everyone to this introduction to clinical cytogenetics. In this presentation, we'll explore how chromosome disorders contribute to genetic diseases. Now, cytogenetics is pivotal in medicine, as cytogeneticists were the first to integrate a genome-wide perspective into medical practice. Chromosome analysis has been essential for diagnosing and understanding numerous genetic conditions. In this PowerPoint, we'll walk through the clinical indications for your patients, the different analysis techniques used from cytogenetics to molecular, and the applications of cytogenetics in providing the right diagnosis for your patients. Chromosome analysis is performed for several clinical indications, and these include developmental delays, intellectual disabilities, infertility, and recurrent miscarriages. It's also used in diagnosing different hematological malignancies, such as leukemia, where specific chromosomal abnormalities often indicate prognosis and guide treatment. An example that comes to mind is the BCR-ABL gene fusion translocation between chromosomes 9 and 22. This finding not only helps with the diagnosis of chronic myeloid leukemia, but it also helps target the disease with specific treatment. This makes cytogenetic testing a critical part of the diagnostic workup for many of your patients. Now, chromosomal disorders are actually more common than many realize. They're responsible for around 50% of first trimester pregnancy losses and 1% of live births. Chromosomal anomalies contribute to many congenital malformations and cancer, highlighting the importance of cytogenetic analysis in clinical practice. Now, you as future doctors will hopefully make use of the information provided in this presentation to carefully select this cytogenetic or molecular technique that best suits your patient's clinical presentation. And this will hopefully provide the information required for making either a positive or negative diagnosis. Now, the two primary cytogenetic techniques are G-banding and fluorescence in situ hybridization, or FISH for short. G-banding or karyotyping remains the gold standard for detecting large chromosomal abnormalities, allowing the visualization of the entire genome, looking at the entire chromosome complement of a patient. FISH, on the other hand, uses fluorescent probes to target specific genes or chromosome regions, offering a higher resolution but limited genome coverage. We'll start with G-banding or karyotyping, which is fundamental cytogenetic technique, where chromosomes are stained with a Gamesa stain to reveal distinct banding patterns. This technique allows for the visualization of all chromosomes in a single cell, showing us both large structural abnormalities as well as numerical changes in the genome of a patient. It's quite quick, it's relatively non-invasive, and remains a go-to for many clinical applications. And we'll go through what they are in the next slides. I just wanted to go through the chromosome harvesting process with you, and it's a very meticulous process. So usually blood samples are cultured with a nutrient-rich medium to stimulate cell division, and then they're treated with colchicine to arrest cells in metaphase. After being stained with Gamesa stain, chromosomes are visible under a microscope for a detailed analysis. Each step is really important in ensuring high quality slides for reliable results. So please take your time at a later stage and familiarize yourself with the different steps required for chromosome harvesting. Now, you as doctors will never have to do this, but it's a quite interesting process to learn. Now, chromosome structure includes heterochromatin and euchromatin regions. And we need to know this because depending on where your deletion or duplication lies, it really is important for the diagnosis of your patient. Now, heterochromatin is densely packed, often gene poor and stains dark. In contrast, euchromatin is gene rich and stains lighter, reflecting its active role in gene transcription. Now, this structural distinction is key in identifying abnormalities during analysis, as I mentioned. In clinical cytogenetics, chromosomes are classified based on size, the position of the centromere, and the banding patterns. Now, the P arm refers to the top part of the chromosome, while the Q arm refers to the bottom part of the chromosome. The constriction of on each chromosome is referred to as the centromere, and really, depending on whether you're looking at a metacentric, submetacentric, or acrocentric chromosome, the centromere is usually located at a different position as seen in the diagram. The telomere refers to the tips of the top and the bottom of each chromosome. And this helps us when we find rearrangements as we can correctly communicate the location of the abnormality. For example, telomeric or terminal deletions or duplications involve the tips of the chromosomes. Interstitial deletions or duplications involve the middle section of the chromosomes. Each chromosome has unique characteristics that help us pinpoint abnormalities and understand their implications in various genetic disorders. So G-band and karyotypes are actually used for detecting balanced rearrangements, such as inversions and translocations. And these rearrangements are often investigated in cases of recurrent miscarriage or infertility, where balance changes in parental chromosomes may lead to unbalanced outcome in offspring. As cytogeneticists, we usually look at 5 metaphases under the microscope and examine each band on each chromosome, as well as count 20 cells to ensure a 46 chromosome complement to exclude mosaicism. And I'll explain what mosaicism is in further slides. Another cytogenetic technique is fluorescent in situ hybridization, or FISH. FISH is a targeted technique that uses fluorescent probes to highlight specific genes or chromosome regions, such as microdeletions or translocations. It does have a higher resolution and is very useful in cancer diagnosis, prenatal testing, and identifying abnormalities in cases where rapid results are needed. So compared to karyotyping, FISH usually only takes 1 to 2 days from setup to analysis to reporting, comparing to karyotype, which takes 2 to 3 weeks from start to finish. FISH is essential in diagnosing various genetic conditions. For example, it can detect microdeletions such as in DeGeorge syndrome, where there is a deletion on 22q11.2, or amplification such as HER2 amplification in breast cancer. In prenatal testing, FISH helps assess aneuploidies, providing quick diagnostic insights into conditions like Down syndrome, which has 3 chromosome 21s instead of 2. Now we'll be discussing some molecular techniques, namely multiplex ligation dependent probe amplification, or MLPA for short, chromosomal microarray, or CMA for short, and whole genome sequencing, or WGS for short. We'll start with MLPA, and it's a targeted copy number assay, and it's used to detect exon level deletions or duplications. Unlike FISH, MLPA actually uses PCR to amplify the DNA, whereas FISH doesn't need to amplify DNA. And it measures DNA from specific regions, such as the 22q11.2 deletion in DiGeorge syndrome. And I'll show you an example of an MLPA image of an abnormal result in the next slide. So the y-axis on this graph, it shows the normalized ratio of probe signals indicating the copy number of specific regions. So a ratio of 1 represents a normal copy number. Ratios above 1 suggest a duplication or a triplication, while ratios below 1 indicate a deletion. On the x-axis, we have specific genes or target regions, each analyzed using MLPA probes. Now, each gene or region is labeled here with a corresponding data point that reflects its copy number based on the y-axis ratio. So in this example, this patient was suspected to have DiGeorge syndrome, and MLPA was requested to specifically target the 22q11.2 region. The probe shift to 0.5 indicate a deletion in the 22q11.2, and the x-axis show the specific genes corresponding to the deleted region. So as I mentioned, 1 means there's 2 alleles. Anything below 1, so 0.5 means there's a deletion. Anything above 1, so 1.5 means there's a triplication. Hope this makes sense. Another molecular technique is a CMA, which is a powerful tool for genome-wide analysis. So just like a karyotype, it examines all the chromosomes in a cell. So using DNA probes, CMA detects copy number gains and losses across the genome, making it highly effective in identifying abnormalities in children with developmental delays or birth defects. It is a much higher resolution than a karyotype. CMA screens the entire genome, as I mentioned, by comparing patient DNA to a reference genome, and that is your control patients. It uses DNA probes to detect copy number changes like gains or losses, and this helps identify abnormalities in the chromosomes. CMA is especially useful, as I mentioned, in diagnosing unexplained dev delays, intellectual disabilities, and birth defects in children. Now, compared to karyotypes, which has a 1 to 3 detection rate for ambiguous referrals, CMA has a much higher rate at 15 to 20%. This increased diagnostic yield has made CMA the preferred initial test over traditional karyotyping. Now, this slide is actually a really busy slide, but bear with me. I just wanted to illustrate how a 20q11.2 deletion is detected across different genomic techniques that we've discussed so far. So first, on the left, we have MLPA, which shows the deletion with a reduced signal ratio in the target region, indicated by the red arrow labeled del22q. MLPA, as I mentioned, is a targeted method and can detect small deletions and duplications at specific regions by measuring the copy number changes directly. In the center just below, we see a CMA, and this method provides genome-wide view. So we can look at chromosomes 1 to 22, as well as your 6 chromosomes X and Y. CMA is highly effective in identifying copy number changes across the entire genome, making it especially useful for detecting large and small deletions like this one with higher resolution than traditional methods. So the drop-in signal at the 22q11.2 location is marked by the red arrow, and this indicates a deletion in our region. On the top right, we have the G-banded karyotype, and this conventional cytogenetic method reveals large structural changes in the chromosomes. Here, the deletion at 22q11.2 is indicated by the arrow, but it's actually harder to detect because karyotyping has a lower resolution. It often misses smaller deletions, so this technique is actually less sensitive for subtle chromosomal changes like 22q11.2. So you really need an experienced eye to actually detect those really subtle chromosomal deletions. Finally, at the bottom right, we have FISH. And this technique, as I mentioned, uses fluorescent probes to specifically target the region of interest, such as in 22q11.2. This shows up as a missing signal when a deletion is present. Now, FISH is highly accurate for specific regions and can confirm a deletion, but it doesn't provide information on the rest of the genome like a CMA does. In summary, each method has its strengths. MLPA is good for targeted deletions. CMA provides genome-wide detection with a higher resolution. And karyotyping shows large-scale changes. And FISH offers a precise region-specific confirmation. Now we can focus our attention on another molecular technique, which is whole genome sequencing. Now, this method is usually used for referrals of cancer, such as breast or ovarian, with or without family history. This is where we only include a few genes to investigate for a patient. Short-read sequencing is usually used for gene panels where a number of genes can be investigated at once. In regards to long read, we would expect referrals for cancer where maybe a balanced translocation has taken place between known fusion chromosomes, such as in chronic myeloid leukemia. We can even investigate repeat sequences or look at AGG repeats for Fragile X syndrome, something actually short read is not capable of as yet. Now, this slide compares short read and long read sequencing in genome analysis. Short-read sequencing produces shorter DNA fragments, which can create sequence gaps and limits variant detection due to incomplete genome coverage. Now, in contrast, long-read sequencing, shown here as hi-fi reads, produce longer DNA fragments that map uniquely across the whole genome. Now, this reduces gaps and allows for more comprehensive variant detection, making it especially useful for detecting large or complex genomic changes. Please have a look at the table at a later stage and see how the two techniques differ. The main differences really I want you to note and take away is that they are used to detect different types of abnormalities. Short-read sequencing is better suited for point mutations and is great for cancer diagnosis, such as in breast cancer for BRCA1 and BRCA2. Long read, on the other hand, can detect balance rearrangements, which is useful in CML diagnosis and the detection of repeat sequence mutations, such as Fragile X. For this section of the PowerPoint, I'll be discussing the different types of chromosome abnormalities, how they arise, and the potential clinical significance of the different types on the carrier, as well as risk to their offspring. You've heard me speak of aneuploidies, rearrangements, mosaicism, etc., and they'll all be discussed in the next few slides. We'll start with aneuploidy, which is the most common type of chromosomal abnormality and includes conditions like trisomy 21, which is Down syndrome, Klinefelter syndrome, and Turner syndrome. Understanding these abnormalities is crucial for diagnosing and counseling your patients, as well as providing insights into the genetic origin. So for aneuploidy, I would say that most of you are familiar with trisomy 21, which causes Down syndrome. Now, Down syndrome patients usually have a distinct appearance and clinical features at birth. And for you as a doctor to confirm this diagnosis, you might request a G-banded karyotype, or you might request a FISH or microarray. All of these Cytogenetic or molecular testing methods will give you a diagnosis, but I would say FISH is probably the most commonly used because it is cheaper. It's more targeted, so it would target your chromosome 21s and much faster. So your patient would get a result within 1 to 2 days. I also need to explain to you regarding inheritance. This slide explains why individuals with chromosome aneuploidies, such as trisomy 21 or Turner syndrome females with a missing X chromosome, or Klinefelter males with a 47XXY complement, generally do not have an increased risk of passing these aneuploidies to their offspring. This is due to three main reasons. The first would be meiotic mechanisms, which means that these are errors that are random and are not inherited. Also, individuals with, say, Down syndrome or Turner syndrome or Klinefelter syndrome have reduced fertility, and this limits the chance of transmitting this aneuploidic cell line to future offspring. Also, the fact that these are sporadic occurrences, which means that most cases are new mutations and are not genetically predisposed. I also need to speak to you about the importance of non-disjunction and why some individuals end up with trisomy 21 chromosome complement while others do not. Of course, these errors become more likely with age, and this is why older mothers above the age of 35 years have an increased risk of having a baby with Down syndrome. The next two slides will help explain what types of errors occur in meiosis that lead to abnormality and how this leads to abnormal chromosome complement in offspring, although the parent has no abnormality themselves. Now in this diagram, we see meiosis, a cell division process that creates gametes with half the usual chromosome number. Meiosis consists of two stages, meiosis 1 and meiosis 2. Under normal conditions, chromosomes separate equally, producing balanced gametes. However, in non-disjunction, which is illustrated here in two scenarios, chromosomes fail to separate properly. Now, this results in gametes with either an extra chromosome or a missing chromosome. So an extra chromosome leading to something like trisomy 21, a missing chromosome leading to something like Turner syndrome, which is missing an X chromosome. Now, such abnormalities can lead to genetic disorders if these gametes are involved in fertilization. Now I'll take you through the abnormalities of chromosome structure. Structural chromosomal abnormalities such as reciprocal translocations and inversions can be balanced or unbalanced. While balanced rearrangements often have no immediate effect on the carrier, unbalanced changes can disrupt gene function and are linked to various genetic disorders such as chronic myeloid leukemia and the BCR-ABL gene fusion translocation. Structural abnormalities occur when chromosomes break and rearrange. Deletions and duplications lead to imbalances in gene dosage, while translocations can disrupt normal function. I will be going through the two different types of translocations in the next few slides. This slide presents the different types of chromosomal abnormalities, and I've taken the information right out of your book and just popped it into a table format for easy comparison. So the first one is a terminal deletion, which is a loss of the chromosomal end segment. Interstitial deletion, which is a loss of an internal segment of the chromosome, so it involves the middle section of the chromosome. Duplication, which can be also terminal or interstitial, and this is where a segment is copied, results in a extra genetic material. A ring chromosome, this is when the ends or the tips of your chromosome, the terminal ends, are deleted and then they fuse together and it forms a ring structure. Those are usually quite unstable and break apart in cells, so they're usually mosaic in nature. Isochromosomes is when one arm is missing with the other duplicated. So this is your cell's way of trying to balance an imbalance. It duplicates itself when there is a deletion. A Robertsonian translocation is a fusion of two acrocentric chromosomes, and I don't know if you remember, but acrocentrics are the ones with the satellites and the centromere right at the top. Reciprocal translocations is when there is an exchange of segments between chromosomes that other than acrocentric, and they're usually balanced. And each type can have different impact on health depending on the genes affected. So as I mentioned, I will be discussing the different types of translocations, and we'll start with reciprocal. And this involves breakage and rejoining between non-homologous chromosomes. They're often balanced, but can be inherited in an unbalanced form in offspring and can cause recurrent miscarriage and also infertility. So they're really important in identifying those in prenatal testing or recurrent miscarriage cases. So a karyotype is definitely the most useful tool in this case because, as you remember, microarray does not detect balanced rearrangements, but karyotype is very useful in detecting large chromosomal rearrangements such as translocations. So as I mentioned before, reciprocal translocations are often balanced and pose no risk to the carrier, but can lead to unbalanced gametes, which means they can be unbalanced in offspring. So in this slide, it shows how chromosome translocations can lead to different gamete outcomes. So in meiosis, chromosomes form a quadrivalent structure to align and then they segregate. During the segregation, there are three main patterns that occur. We have adjacent 1, adjacent 2, and alternate. In adjacent 1 and adjacent 2, segregation produces unbalanced gametes, which can lead to genetic disorders or recurrent miscarriage in the carrier. Alternate segregation, on the other hand, results in balanced or normal gametes, and this preserves the genetic material. This really explains why some individuals with translocations may have a reproductive challenge and have recurrent miscarriage, or can pass on chromosomal abnormalities to their offspring, or can also produce balanced gametes through alternate segregation. So the other type of translocation that is balanced is a Robertsonian translocation, and this is where two acrocentric chromosomes fuse near the centromere. And as you can remember, acrocentric chromosomes are those that have a satellite at the top and the centromere right at the bottom of that satellite. And carriers are usually asymptomatic, so it poses no risk to the carrier themselves because it's balanced, but they do face a reproductive risk, such as an increased chance of having a child with Down syndrome, especially in cases where acrocentric chromosomes, such as 14 and 21, fuse and become translocated. Now we can go through mosaicism, and I'm sure I've mentioned this previously in this PowerPoint, but hopefully in the next few slides I can explain what it is. So mosaicism actually occurs when an individual has two or more different chromosome complements. This can arise from early non-disjunction events and often result in milder phenotypes compared to non-mosaic cases, such as mosaic Down syndrome, when a Down syndrome child has a 47 XY or XX plus 21 complement as well as a normal cell line. So detection methods can be either a conventional karyotype, and this just involves counting up to 50 cells. Interface FISH, which is a little bit higher resolution than a karyotype, and this would be counting up to 50 or 100 cells, or a CMA, which can detect down to 5% mosaicism in a patient. So what is the impact of mosaicism on the patient? We know that mosaicism occurs early in development. leading to two or more population of cells with different genotypes within the same individual. The mutation happens after fertilization in the developing embryo, and this results in some cells carrying the mutation, while others are normal and do not. And this, of course, would cause varied expression in different body regions. But the true impact really depends on different factors. So the timing of non-disjunction, the type of chromosomal abnormality, so what chromosome is involved, what chromosomal region is involved, is it a whole chromosome, is it a ring chromosome, the proportion of mosaic cells, so is your proportion of abnormal cell line higher than the proportion of normal cell line in the patient? If that's the case, then it would have a higher impact. And the affected tissues, so is it just in the brain or is it just in the skin cells? Of course, if your high number of mutation cells are in your brain, it would have a higher impact than it is if it was in your skin cells. And mosaic individuals, such as mosaic Down syndrome, usually have a milder phenotype compared to non-mosaic because your normal cell line actually buffers the impact of the abnormality in the patient. Now, in this last section, I'll go over cancer and cytogenetics and the importance of chromosomal analysis, detection, and treatment options. Chromosome analysis is actually really important in cancer diagnosis, as somatic chromosomal abnormalities are a hallmark of many cancers. Cytogenetic techniques help identify tumor-specific genome changes, guiding both diagnosis and target therapy decisions. So in this slide, I've included some examples of chromosomal abnormalities and their link to cancer. Translocations, for example, between chromosomes 9 and 22 lead to a gene fusion event and chronic myeloid leukemia. Another example would be a 12-21 translocation leading to acute lymphoblastic leukemia. These abnormalities not only contribute to genomic instability in the patient, but this drives the cancer progression by promoting tumor formation, the recurrence of this tumor, poor survival of the patient, and drug resistance later on. Now, the table on the left actually lists specific translocation, fusion genes, and their associated cancers. And these are usually detected via karyotype or a FISH test. And this also helps us not only diagnose a specific cancer, but also select the specific drug that targets that cancer. So as I mentioned, cytogenetic and genome analysis helps us correlate tumor types with specific genomic changes. This is key for assessing the therapies which are effective and can lead to managing the cancer in patients, which I will be speaking about in the next slide. This summary really highlights the role of targeted therapy in treating cancer based on specific genomic changes. For each cancer type, particular genomic alterations drive the disease, and this can be targeted by customized therapies. These targeted treatments aim to directly address the mutation or abnormal pathway involved in the cancer. This increases treatment effectiveness and minimizes damage to healthy cells. This table here lists examples of cancer types, their associated genomic changes, and corresponding targeted therapies. Please take a moment and look through the different types at a later stage. I think the main example, which I've mentioned throughout this talk, and we see often in my lab, is the detection of translocation between chromosomes 9 and 22. And this, of course, leads to the diagnosis of chronic myeloid leukemia, and thus selecting imatinib as the first-line therapy of treatment for the patient. So thank you for listening to this presentation. I've included my contact details here, so please feel free to either email or WhatsApp, and I will get back to you as soon as I can in regards to explanations of any of the points here that I mentioned on the PowerPoint, or if you'd like me to expand on a particular point, I'm more than happy to do so.